Well, thanks for joining us. We're back with you to bring you more about Homeland Security and national security, right back here to where you live. We're here from College Station, Texas, Texas A&M University, and we're being joined today by Dr. P.K. Carlton, who is the Director of Homeland Security for the Health Science Center at Texas A&M. Thank you very much for being with us.
It's a real pleasure. Thank you for the invitation.
Well, I say Dr. P.K. Carlton. I guess I could also say General P.K. Carlton, because in a previous life you were the Surgeon General for the United States Air Force.
That's correct.
Now, you took a very unique approach to that position. You had a lot of experience with combat medicine, and so before we get to Texas A&M and Homeland Security issues, talk to us just a second about what you did that was new, different, and special in relation to combat medicine as a Surgeon General of the Air Force.
Well, Dave, my experience in combat medicine dated back to the Marine Barracks problem in 1983, where we had some new tools in medicine that we had not had in the Vietnam War. They were the tools of salvage surgery and the ventilator. And after that 1983 experience, we sat down as a group and said, okay, we did exactly what we did in Vietnam. Can you look a mother, father, a husband, a wife in the eye and say no one could have done better? And we said, no, the world has changed. And so it took us 20 years to bring those changes with all the education, the training, the modifications for the military, but to bring those into the forefront so that for this war, all of them were there. The training was there, the pieces were there, the far forward surgery was there, the critical care in the air, the family members being there on day 2 and day 3 to hold these loved ones' hands. And that's resulted in the lowest die to wounds in the history of war.
Well, now that's important for a Homeland Security perspective, because one of the challenges you had was you had to break across a lot of stovepipes. The Army had its combat medicine, the Air Force had its combat medicine, the Navy and Marine Corps had theirs, and you had to find a way to stretch across those, didn't you?
Yes, and stretching across is fairly difficult, and the applicability to come to A&M was exactly the same. Every state does things differently. Every agency within the federal government does things differently. And so how do you bring then an approach to say to the country, we can surge, we can cope with less than ideal circumstances, and remain dedicated to preserving life, was what I came to A&M for.
Now, when you made that jump from the Surgeon General of the Air Force to join us in Homeland Security program here at Texas A&M, talk just a second about how you brought those ideas to bear, because those were not ideas that were common to medicine, civilian medicine, the idea of having to do triage, large number of casualties and so forth.
Well, we taught the whole idea of surge medicine. We had combined programs with our College of Architecture, with our College of Engineering. We fit well with the TEACS, NERTC, the National Emergency Response and Rescue Training Center, who were focused on other than the hospital. So it was a nice combination. And in a sales program that was teaching people how to do something they never wanted to think about, we addressed this. We then had the opportunity to play it in Hurricane Katrina, where literally a booklet that we'd put out from our College of Architecture Health Science Center program on how to build a surge hospital, people opened it and did it in Dallas, in San Antonio, in Houston, in College Station, and in Baton Rouge. That pushed things along very, very nicely.
Let's take just 1 minute and tell us one other special thing that you worked with, talking about surge capabilities. Here at Texas A&M, they had to do with an animal hospital. Would you discuss that?
Yes, we had identified that the requirements for a surge hospital are space and ingenuity. And so we'd identified an opportunity with our large animal hospital here, a superb place, where we had oxygen, where we had backup power, we had tremendous amounts of space, that we could handle more than 1,000 patients in a surge situation. And then, lo and behold, we had to do it for Hurricane Rita. And so it all came true. We had then the opportunity to work, how does that work?
Well, let's take all that background, Surgeon General of the Air Force, running the Homeland Security program here at Texas A&M, working with state and local hospitals, and let's apply that and ask you to step forward and talk about flu for just a second. We've been through this discussion of H1N1. Everybody was all spun up, now everybody's all spun down. Give us from your experience, your perspective on what we've seen thus far, what we should expect to see in the future.
Well, what we've seen thus far, we're now beginning to get a complete picture. It's been a full month since the world's been aware, but it's been 3 months since we've seen the problem. It surfaced in La Gloria, Mexico in February of this year. The health department then got involved in March. By the time they finished their testing and we found out we'd seen something that looked new, it was middle April, and the world became aware of it. By that time, we had cases in Texas, Texas in California, Texas, all over. And so it literally had become a worldwide issue very, very quickly.
Now, you've talked about that for many years. You anticipated that. What surprised you in either a positive or a negative way about the way this flu sort of unwrapped?
Well, the very positive part of this was that there was a national awareness, that we had a plan. The plan worked very nicely. We learned some things in terms of we're in the middle of a pandemic. The however is we didn't factor in lethality. And so everyone's a little bit relaxed right now that this did not turn out to be as lethal as we had expected it to be. But if you're a student of history and you go back to 1918, right, what we saw was Spanish flu came in late spring, then vanished for about 3 months, and then surfaced again this late spring discussion, very, very low lethality. And then when it came in the late summer, early fall, a higher lethality. And we suffered then 50 million deaths worldwide. Over. So it's not over by a long shot.
Now, it's always easy to second guess people in hindsight. We saw a lot of schools close. We saw universities make decisions about graduation exercise. We saw some sporting events canceled. In hindsight, is that overreaction, or were people being properly cautious just because you never have enough information until it's too late?
I believe that was being properly cautious. I believe based on the information they had, they made very intelligent decisions that said, can we do this some other way, still accomplish our mission, yet not expose people to the risks until we know more information. So I don't believe anybody overreacted.
We've got just about a minute left. Would you share with us, Dr. Carlton, your thoughts on how we, either as individuals or businesses, ought to get ourselves ready for what's going to follow on and appear again when the weather gets cold next year?
Well, the great concern is that we probably have 3 to 4 months to now do what we should have been doing all along. That means to look and find out, okay, do we teach our school children how to cover with a sneeze, how to cover a cough, how to wash their hands properly, how to do the things that involve lowering transmissibility? The other piece that we haven't really paid attention to is how do we handle the inside threat? When someone coughs or sneezes in an emergency room, for example, how often did they infect other people within the emergency department? We know SARS started with 1 index case in an emergency department in Canada. In close proximity, 4 other cases were infected. And so we're now beginning to address the airborne threat as well as the other threats. So this will be a very busy 3 to 4 months.
Are businesses taking proper precautions, or are you concerned that they've relaxed a little bit too much?
Well, there's a bit of a deep breath going on. It says, oh, we dodged a bullet. And so I believe businesses are going to look and say, okay, what really should we do now? Because all the public health measures involve social distancing. Social distancing is horrible for business.
Social distancing is where we stay out of the mall, where we close a school, where we don't go to the movies, we pull down churches and so forth.
Exactly. And that's the antithesis of a happy business environment. And so the balance between proper public health and proper business is the most difficult one for our public health officials to reach.
I guess the key to that is that leaders have got to step out and explain to the public what's going on.
That's exactly correct. And that's our job right now, is to make sure our leaders are well informed.
Do you have a thought about where people might go for personal preparedness as they see moms and dads, as they see the flu season come on next fall? Where would you recommend they check?
The Center for Disease Control has some wonderful websites about Center for Disease Control, how to protect yourself, how to protect your loved ones, what's smart, what's not smart. So I would advise people to go to that website, yes.
Okay. Well, Dr. P.K. Carlton has been the Director of Homeland Security for the Health Science Center for several years here at Texas A&M. We really appreciate the expertise that you brought out of combat medicine into the field of Homeland Security. I know you've been have a national reputation in that area, and then we also appreciate very much what you're doing for us here at Texas A&M. Hope you enjoyed that, and you'll stay with us for more on our channel, whether it's here on this television channel or whether you join us online, where we take issues of Homeland Security and national security and bring them home to you.